I think I diverge from a lot of people, even among my members and so on, when I say I have zero, absolutely no problem with the removal of user fees.
According to a 2013 Capri Health Access study, doctors and nurses outlined that the abolition of user fees had its most far-reaching impact on pharmaceutical supplies, followed by staff and medical supplies. How much does the government spend annually on pharmaceuticals, and by what percentage is that cost projected to increase in the next few years? And secondly, how has the no user fee policy impacted the culture of putting aside a portion of one's income for healthcare?
Okay. If you get a copy of my sectoral, have a copy here? It's online. You can direct it. It will give you the specific details of the budget for drugs. Or it may vary a little, but the NHF budget, I think it's 9 billion, and it's aiming. No, I think this year is what, 11 billion. The NHF expenditure is closer to 11. But just to be very sure, let's refer back to that. But it's increasing at a rate.
Yes, 11 billion for last 11 billion for 21.
Exactly. It's increasing at a rate where I indicated, based on the forecasting and the demands and the increasing cost, that the government will have to provide about 40 billion over the next 3 years, I think, to support the NHF, which is a primary provider, not the exclusive, but primary provider. And then we singled out certain types of categories based on demand, like hypertension, drugs, which has shown significant increase, and so on, diabetes. So the point is, the answer to the first is that costs are high and are getting higher. But what was interesting, again contained in the report in my sector, is the cost to individuals, the co-payments. You can remember now, there are segments in the NHF as part of the beneficiaries that you have to pay some towards it. And those costs have also been going up. So from the standpoint of the people's ability to afford, the truth is it's hitting them harder in the pocket. And I'm going to ask one of you to ask Dr. King. Notice I'm saying you ask him. I'm asking him through you, right? Because I don't want to be on that side of the table. About the link between health and economics. Because one of the reasons why he's appointed, and he has graciously agreed, is to establish the economics of healthcare. Because when we talk about economic growth and economic development, sometimes health is missing from it. But back to the question, this is personal economics now. It is hitting people, Jamaicans, in their pockets and making more Jamaicans vulnerable. Indeed, a 2016 report showed that a third of our Jamaican population have no access to health care in terms of being able to afford certain things. So again, if you consult this study, it will show which was the whole basis for which I had to be concerned as minister to say, listen, there are people who, even with universal access, are being denied the best possible care for one reason or the other. Or even if they try, they are going to be denied the children's lunch money, or the utility bills, or the food that they need for nutrition, because it's a choice they have to make. And these are real choices. And I think, when you juxtapose that against downtime from sickness to stay home from going to work, and productivity levels, people going there sick because they have to get the paycheck, it casts a much more holistic picture of why health is important. The increase in price of selected pharmaceuticals covered by the NHF, 2017-2022, 8 of 10 drugs under consideration had price increases greater than 100%. Examples of the price variation in commonly used pharmaceuticals includes paracetamol, 785%, dextrose, 5% in normal saline, 87%, morphine powder, 117%. Over the 2020 to 2021 period, Jamaicans spent 2.38 billion, it's out of pocket, in NHF co-payments on drugs to treat high blood pressure, compared to 1.46 billion for the period 2014-2015. That's a 62% increase just for hypertension co-payment. And they also spent 1.5 billion, these are approximate, on the drugs for diabetes for 2020-2021 period, compared to 866 million for 2014-15, which is a 82% increase. Again, examples of how much the cost is going in one direction, and more people are ill. So it's really an alarming statistic.
I think I diverge from a lot of people, even among my members and so on, when I say I have zero, absolutely no problem with the removal of user fees. None. What I have a problem with is the lack of commensurate funding for the services that we're not. My evidence for the usefulness of removing the user fee is exactly the opposite of what everybody else says, which is when we remove the user fees, we ended up with overflowing wards. What that means is that before the user fees were taken away, all of those people who needed to be admitted were not coming to hospital because they could not afford it. And I mean, I don't know if you can run a country like that. That is, to me, an indictment on what we are doing for health funding. So it tells us that we need this report, and not just the report, we need what comes out of it to be telling us that this is the way to solve that particular kind of problem, the lack of access. Because lots of people have tried it. I think they tried it in Thailand, they tried it in Moldova to remove the user fee, and what they realized was exactly what we found. Right? So there needs to be a mechanism to implement the three things that I said: universal access, universal coverage, same thing basically, quality health care, and lack of, and protection, financial protection.
It was actually replaced in the budget by more than what was lost in user fees when it was initially implemented. So 2 billion collected in fees, and it was replaced by 3 point something billion in the budget. May not have been enough, but it was replaced.
Mm-hmm.